Estimados doctores, muy buenas noches. Sean ustedes bienvenidos a esta 10ª conferencia virtual del Laboratorio Médico del Chopo y la última del año, esta que hemos realizado en colaboración con nuestro socio comercial, Patia. El día de hoy vamos a hablar de una prueba súper innovadora para diabetes denominada Glycomark, para lo cual tengo el gusto de presentarles al doctor Eric Bottom. Él es maestro en ciencias por la Universidad British Columbia, es biólogo por la Universidad North Carolina and Chapel Hill. Tiene una amplia experiencia en medicina de precisión con el desarrollo de algoritmos para diabetes mediante el uso de nuevos biomarcadores. 18 años de experiencia en el lanzamiento de pruebas revolucionarias para la detección temprana, prevención y manejo de diabetes y prediabetes, y más de 25 años de experiencia creando canales especializados para impulsar nuevas tecnologías como herramientas clínicas complementarias que mejoran el manejo de la diabetes y el cáncer. Doctor Eric Bottom, sea usted bienvenido. Muchísimas gracias por estar aquí el día de hoy con nosotros. Yo soy la doctora Violeta Guerrero, llevo la subdirección operativa de gabinetes en Grupo PROA y les doy la más cordial de las bienvenidas. Welcome, Dr. Eric Bottom. Thank you for being here today with us, and please share with us.
Thank you for the introduction. Today we are going to review the FDA-cleared Glycomark blood test. I had the very good fortune of doing the original scientific work on this test with Dr. John Buse at the University of North Carolina. John, at one point, was the president of the American Diabetes Association. But more specifically in this presentation, I'll review how Glycomark can identify and manage diabetes for better outcomes. All of you are familiar with the complications of diabetes: retinopathy, nephropathy, neuropathy, cardiovascular complications, cognitive decline, and macrosomia, high birth weight. And as you'll see, Glycomark is uniquely associated with most of these complications, primarily due to the test's ability to measure postprandial hyperglycemia or after meal glucose levels. Let's quickly review some of the basics of the current diagnostic tools for glycemic control to put the unique characteristics of Glycomark in perspective. We're all familiar with A1C, and A1C reflects average glucose levels over 2 to 3 months. It's an excellent marker for diabetes, but as you'll see, its primary strength, the ability to measure an average, can actually be disadvantageous in measuring postprandial hyperglycemia. Finger stick blood glucose levels we're all familiar with. The oral glucose tolerance, or as it's known, is OGTT, used to be known actually as the gold standard diabetes test, which has now been essentially supplanted by hemoglobin A1C. But the OGTT, oral glucose tolerance test, is very time consuming, as you all know very well, although clearly used routinely in pregnancy. Fructosamine and glycated albumin are essentially what I would call mini A1Cs, reflecting glucose not over 2 to 3 months, but over 2 to 3 weeks. We all know CGM very well. It's a wonderful tool, but at least in the US, it's not all that well reimbursed. And the Glycomark test is a bit unique compared to all these other tests in that it actually measures postprandial hyperglycemia, or we could call it glycemic variability, over a period of 1 to 2 weeks. I should also say that new studies show that the Glycomark test is a biomarker, and this is brand new data, but is a biomarker of short-term SGLT2 drug effectiveness and compliance, and we'll go over that in some detail. Continuing with biomarker comparisons, here you see the actual time frames of glucose reflections. A1C 2 to 3 months, fructosamine again 2 to 3 weeks. Blood glucose is actually 1 point in time, and Glycomark, which reflects postprandial hyperglycemia over 1 to 2 weeks. So, what does Glycomark actually measure? It measures 1,5 and whoops, sorry about that. It measures 1,5, a little technical glitch, but I think we can continue. It measures 1,5 anhydroglucitol, a monosaccharide, or 1,5-AG as we call it for short. And it measures 1,5 anhydroglucitol in blood. 1,5-AG is chemically similar to glucose, except for the absence of one hydroxyl group, as you see here circled. However, this difference in one hydroxyl group changes the physiology and biology of 1,5-AG compared to glucose quite significantly. One simple fundamental difference that we all need to keep in mind is that when glucose levels increase, 1,5-AG levels decrease. So why do 1,5-AG levels decrease with hyperglycemia? It's pretty simple, actually. When glucose levels exceed the renal threshold, glucose is excreted in urine, and due to the molecular similarities of 1,5-AG and glucose, 1,5-AG is also excreted in urine, depleting the levels of 1,5-AG in blood. So higher glucose levels in blood translate into lower 1,5-AG levels in blood. So the higher the glucose, the lower the 1,5-AG levels. And these changes are typically seen in 3 days, with results representing postprandial hyperglycemia, glycemic variability over 1 to 2 weeks. Here we see a schematic of the 1,5-AG glucose mechanism. First, the source of 1,5-AG is food, so you actually ingest it. During normal glucose control, as you see here in green, both glucose and 1,5-AG are filtered in the kidneys and reabsorbed by the body. And urinary 1,5-AG is equal to the 1,5-AG that is actually ingested, with circulating 1,5-AG being maintained at higher normal levels. During hyperglycemia, as you see here in orange on the right, and when glucose exceeds the renal threshold of glucosuria, which we all know is greater than approximately 180 milligrams per deciliter, urinary glucose blocks the reabsorption of 1,5-AG, and 1,5-AG is excreted in the urine, reducing the levels of 1,5-AG in blood, meaning that lower 1,5-AG serum levels are abnormal. So that's a lot to digest in terms of physiology, but probably the main simple point is that when glucose levels are higher, 1,5 Ag levels are lower, and essentially measures glucose levels above 180 milligrams per deciliter, the renal threshold of glucosuria. And that allows 1,5 Ag to actually measure just the higher postprandial glucose levels. Here we see the actual reference and abnormal ranges for Glycomark. Overall, the normal range is between 9.7 and 31.4, with abnormal being less than 9.7. There are gender differences, which you see here, with abnormal being less than 10.7 for males and less than 6.8 for females. I myself, having been involved with Glycomark for over 15 years, I tend to use the value of 10 as kind of a shortcut, if you will. Above 10 is normal, below 10 is abnormal. So 10 really becomes the critical variable. Let's talk about A1C, which we all know is an average of glucose over 2 to 3 months. And as I said before, the average is both an advantage and somewhat of a disadvantage. An average, as we learn in statistics, it's one of the first items you learn in a stats class, is a nice, convenient measure, but it can mask highs and lows. You can have very high highs, very low lows, and have a nice average that can be somewhat deceiving. And that's what we're talking about when it comes to A1C, as you see here. For example, in this scenario with 2 different daily glucose profile, while the A1C level is 7.0, which is a wide range of estimated average glucose, by the way, there is significantly more glucose variation in the orange patient versus the blue patient, where it's pretty clear that the orange patient is not under good control, despite a good A1C level of 7.7%. A1C in these scenarios are just not seeing the more extreme glucose highs and lows because they're essentially being averaged out. Glycomark, as you see, specifically measures the glucose highs or postprandial hyperglycemia in a way A1C cannot. And here you see Glycomark reflecting those postprandial glucose levels. And we see here the actual CGM profiles over 7 days for 2 different patients with identical A1C levels of 7.4. And these graphs are from a study we published in Diabetes Care with John Buse several years ago. You can clearly see that patient 2 has significantly more postprandial hyperglycemia than patient 1. I think that's pretty obvious. And these postprandial glucose levels are clearly reflected by 1,5 Ag levels of 12.4 in patient 1 and 4.5 in patient 2. Remember, lower is abnormal, despite identical A1C values of 7.4. Clearly, this is elevated postprandial hyperglycemia that A1C would have missed, but again, is readily detected by 1,5 Ag. And there you see the Glycomark values. So how much postprandial hyperglycemia does A1C miss? In two studies, one by Erlinger et al. And another by Professor Bonora's group in Italy, nearly 40% of patients who supposedly were in good control as determined by A1C had significant postprandial hyperglycemia, 40%, meaning that these patients were not controlled properly for glucose, although A1C was telling them it was. And that's a pretty big miss, considering that postprandial hyperglycemia is associated with a variety of complications. And this is FYI. This was an interesting treatment algorithm that Quest Diagnostics originally developed for Glycomark to suggest different treatment paths depending on Glycomark values. And with Glycomark values less than 8, which is indicative of higher postprandial glucose values, drugs targeting postprandial glucose levels would be recommended, like the class of GLP-1 drugs like exenatide, et cetera, which are quite popular these days for obesity and other ailments. With Glycomark values greater than 8, which would indicate basically normal PPG values, drugs targeting fasting and mean glucose may be more appropriate, like metformin might be an obvious choice in this circumstance. Okay, let me just get oriented here. All righty. Here we see data from a study by Professor Monnier in France, showing that as patients approach their A1C goal, postprandial glucose has a greater effect on A1C. With patients with A1C values greater than 10.2, fasting glucose contributes 70% of the A1C value, and postprandial glucose contributes 30%. At A1C values less than 7.3, we see exactly the opposite. Fasting glucose contributes 30% of the A1C value, and postprandial glucose contributes 70%, indicating, and this is an FYI, clinically, indicating that management of postprandial hyperglycemia is that much more important in moderately controlled patients. Here we see results from our actual FDA study. We looked at 77 patients with diabetes with suboptimal glycemic control, where patients were treated aggressively over a period of 8 weeks. And you see that the changes in glycemic control were detected significantly earlier with Glycomark than A1C. In fact, the change in Glycomark at 2 weeks was 93%, with no change in A1C, and a 13% change in glucose and a 7% change in fructosamine. So Glycomark changed rapidly over a short period of time, underscoring the short-term control aspect of Glycomark. Continuing with a similar theme, this was a study done in Japan and published in Lancet several years ago, looking at the serial changes in A1C and Glycomark over 6 weeks, where there was a discontinuation of treatment at week 4. With A1C, there was no significant difference between weeks 4 and 6, but with Glycomark, you do see a significant difference with a very, very low p-value, again underscoring the ability of Glycomark to change over a very, very short period of time, and thus can be used when evaluating treatment over the short term. Let's transition a bit and discuss the association of Glycomark to diabetes outcomes and complications. There are now several large studies which show that Glycomark values, and independent of A1C statistically, are associated with a variety of diabetes outcomes, including retinopathy, nephropathy, cardiovascular disease, mortality, stroke, heart failure, cognitive decline, hypoglycemia, and macrosomia, with several of these studies being 10,000 plus patients. And those are pretty large studies. This is a study by Johns Hopkins with an N of 12,308, showing that Glycomark is associated with microvascular complications. With retinopathy, the odds ratio increases to 16 with Glycomark values less than 10, and 16, and I still do a lot of statistics myself. Odds ratio of 16 is pretty darn high. And with chronic kidney disease, the odds ratio goes to 3, which is also pretty high statistically at Glycomark values less than 10, but 16 is almost off the scale. Looking at macrovascular complications, we see similar results. And this was yet another study from Johns Hopkins with an N of 11,000. And I believe this study was published in Diabetes Care, or perhaps Clinical Chemistry. But nonetheless, you see the odds ratios for coronary heart disease, stroke, heart failure, and all-cause mortality in the range of 2 to 3 for Glycomark values less than 10. Again, pretty profound results. In this study of 13,000 patients with diabetes, this is very interesting. Glucose peaks as measured by 1,5-AG were a significant risk factor for cognitive decline and dementia. And the study authors actually concluded that targeting glucose peaks in addition to average glycemia may be an important avenue for prevention. So that is pretty cutting edge. In terms of some of the bread and butter, so to speak, or the basics for the Glycomark test, and simply stated, I should say, Glycomark is a complementary test to A1C and is a specific indicator of recent hyperglycemia, and specifically postprandial hyperglycemia over a period of 1 to 2 weeks. So the test works hand in hand with hemoglobin A1C. Patients to test include type 1 and type 2 patients with diabetes. Glycomark is a non-fasting blood test. I'm going to say that again. It's a non-fasting blood test and can be measured in serum or plasma. And just to say again, I think I said this at the beginning of the presentation, Glycomark is FDA cleared, as well as CE marked, but it's been FDA cleared for several years. In terms of clinical studies and publications, we actually started, I should say, with a couple of publications many years ago. It was two. And we did this research with John Buse at the University of North Carolina, that I mentioned. Those two publications have blossomed into over 1,300 publications from around the world, something we're quite proud of. And some of our more notable studies have come from Johns Hopkins University. We work closely with Liz Selvin's group, Elizabeth Selvin, at Johns Hopkins, and have for many years, looking at a variety of complications and associations with 1,5-hydroglucitol, and again, very large populations. And the new studies keep coming out. And sometimes we're surprised as to what comes out. And one of the big surprises for us over the last several months was the awareness of a new study that's coming out shortly, actually from the Johns Hopkins group, on the use of Glycomark, the specific use of Glycomark as a biomarker of SGLT2 drug effectiveness. And just about everybody is using SGLT2s these days, and we'll go over some of that data towards the end of the presentation. Glycomark has been incorporated in the ADA guidelines and publications, and is specifically included in the ADA medical management of type 1 and type 2 diabetes publications. And I'll just read this, and it comes right out of these type 2 and type 1 ADA books. For type 2, 1,5-AG reflects glycemic excursions, often in the postprandial state, more robustly than A1C, and may be useful as a complementary marker to A1C to assess glycemic control in moderately controlled patients with diabetes. For type 1, the Glycomark blood glucose test measures monosaccharide 1,5-AG in blood, which is a specific index of elevated post-meal glucose levels and short-term glycemic control. The test has proven useful in pharmaceutical research, as well as patient care, when methods are being employed that specifically target glucose instability after meal. And I can tell you, even today, and we know where the Glycomark test is being sold, it's utilized extensively in pharmaceutical studies. Glycomark has also been included in the ADA standards of medical care, and specifically in the section on A1C limitations as an alternative marker of glycemia. Glycomark has also been included in the IDF guideline for the management of postprandial hyperglycemia, and specifically states, and I'll quote, and you see it here on the screen, because 1,5-AG is sensitive and responds rapidly to changes in serum glucose, it accurately reflects transient elevations of glucose within a few days. So how do we use Glycomark in clinical practice? And I'm going to jump to an actual patient case study. This particular patient is 47 years old, has type 2 diabetes with relatively stable A1C values ranging from 6 to 6.8% over the last 12 months or so, with a current A1C level of 6.8. And this particular patient is being treated with metformin, or was treated with metformin. I should say this is actually a patient from Mike Shanek's practice. And Mike is an endocrinologist from the New York area. Glycomark was then ordered, and a value came back of 8.6, which is under 10, which is indicative of elevated postprandial glucose levels. Exenatide, which we all know is a GLP-1 treatment, was then initiated to reduce PPG levels. And we see the results here. After treating this patient with exenatide, A1C was decreased to 6.5, which is good, obviously. And Glycomark increased to 12.5, which is also good, lowering postprandial glucose values. And Dr. Shanek actually writes his analysis of this patient, and I'll just read it. By evaluating glycemic control in a patient with type 2 diabetes with the Glycomark test, recent postprandial glucose levels were detected. With exenatide, the GLP-1, glycemic control improved, as shown by the 45% improvement in the Glycomark value and the 4.7 improvement in the A1C value. Some items to be aware of clinically when using the Glycomark test. Lower Glycomark values can be observed in very advanced kidney disease, liver cirrhosis, also when using acarbose treatment. And SGLT2 drugs, although it's interesting that this is turning out to be advantageous in monitoring SGLT2 drug effectiveness, which I'm going to discuss very shortly. Higher Glycomark values have also been seen with some Chinese medications, although I'm not sure that's particularly relevant here. And I should also note that these conditions affect actual 1,5-AG values in blood and not the assay itself. It's the actual 1,5-AG levels in blood. There are some general recommendations by Dr. Shanek when dealing with abnormal Glycomark results, and perhaps some questions to ask patients. Has the patient been on holiday over the last couple of weeks, which may mean unusual, more, perhaps excessive food intake? Has the patient been taking their prescribed drugs? Was there a recent steroid injection, which would increase glucose, decrease 1,5-AG values? Has there been any illness or recent stress? So these are questions that Mike is thinking about when he's evaluating his patients and using Glycomark. Some follow-up could include post-meal glucose testing at home, along with fasting glucose testing at home. CGM, if economically feasible, would also be an option. And of course, treatment modifications. Here's a list of clinical situations where Glycomark may be useful. When A1C simply doesn't match with glucose results, this could simply be due to postprandial hyperglycemia, which obviously Glycomark can readily detect. When A1C is less than 8 and the patient is supposedly in good to moderately controlled, this may actually not be the case due to elevated post-meal glucose levels. And of course, initiating a modifying treatment based on the identification of postprandial hyperglycemia, in which case you may want to utilize GLP-1 drugs to target after meal glucose levels. Let's switch gears and talk about Glycomark and the SGLT2 drugs, which I've mentioned now, I think, several times. But here I'm going to go over some new data. And I previously said that SGLT drugs reduce Glycomark values, and we've known that for quite some time. And they reduce Glycomark values to values less than 2, which is very, very low for Glycomark, abnormally low. It's been observed recently that lower Glycomark values may actually be now a way to monitor SGLT2 drug effectiveness and compliance. And here you see some results presented at a recent American Diabetes Association conference showing that Glycomark values less than 2 were able to identify which patients were actually taking SGLT2 drugs and being compliant. And you see statistically the ROC curve, AUC, not A1C, but the AUC value for 1,5-AG of 0.82 for all patients, which is a very nice and significant value. Here you see clinical interpretation of Glycomark values and SGLT2 drugs. And this is a table, if you will, that will be not promoting, but informing physicians of when the new SGLT2 drug paper, 1,5-AG drug paper, comes out in the next few months. So 1,5-AG values greater than 10 would indicate good glycemic control and no SGLT2 drug effect. So above 10, no SGLT2 drug effect. Values between 2 and 10, again, no SGLT2 drug effect, but would indicate recent hyperglycemic excursions, postprandial hyperglycemia. And 1,5-AG values less than 2 would be indicative of SGLT2 drug effectiveness. So if you've got Glycomark values less than 2, you can determine within a short period of time, within a couple of weeks, that the SGLT2 drugs are indeed having an effect on the patient. I'm excited to report that this new paper with a very large population supporting these particular data sets will soon be coming out. And when they do come out, we'll be happy to share that information with this group. But these are pretty profound and important results. Last slide and conclusions. Current tests that average glucose levels or generate a single data point can underreport glycemic control. I think we've made that point in this presentation. Glycomark is a clinically proven, FDA cleared, and CE mark test. It's a non-fasting blood test, and is a specific indicator of postprandial hyperglycemia over a period of 1 to 2 weeks. Low Glycomark results, less than 10, are strongly associated with high rates of diabetes complications, even adjusting for A1C and other risk factors. Glycomark results complement A1C to identify patients that may benefit from closer diabetes management. Glycomark results help manage glycemic control, which obviously improve outcomes and, of course, lower healthcare costs. And as you saw with recent data, Glycomark is a specific biomarker of short-term SGLT2 drug effectiveness and compliance. And thank you very much for giving me the opportunity to present today. Thank you again.
Thank you. Thank you very much, Dr. Eric Bottom. Muchísimas gracias por haber estado el día de hoy aquí con nosotros. Y muchísimas gracias a todos ustedes, doctores, que se conectaron a esta última conferencia del año. Y me voy a permitir dejarles un correo para su comodidad, para que puedan ustedes hacernos llegar ahí sus preguntas y sea un poquito más cómodo esta dinámica del día de hoy, en donde con gusto haremos llegar las preguntas al Dr. Bottom para que nos haga favor de responderlas. Muchísimas gracias por habernos acompañado el día de hoy y les voy a dejar también este QR para que puedan ustedes acceder a una landing page sobre esta y otras pruebas de diabetes y prediabetes que tenemos para ustedes. Gracias, muchas gracias nuevamente por estar el día de hoy aquí con nosotros. Que tengan muy buenas noches.